And we will start today. The first lecture is about the most hot topics in head and neck oncology, really hot topics about immunotherapy. And immunotherapy in head and neck cancer, Dr. Tומר is a senior of radiation oncology. He's a GU, but he is also expert in head and neck, and he is in his way to Memorial Sloan Kettering after 2 months. So please, Tומר, come here and start.
So, hello, good evening. I would like to thank the organizers, Dr. Balan and Professor Gil, for inviting me to give this talk about immunotherapy of head and neck cancer. Basically, it's a huge topic. It's impossible to cover this topic within half an hour, even 1 day. It will take a long, long time, but I will try just to cover the basics so everybody not familiar with this area will know a little bit more once I finish. So basically what I will go over through is the immunotherapy background, what's going on in the field or what's going on in developing those treatments, our current data, and the studies that are now being conducted at our center at Rambam. So we all know from the hallmarks of cancer that was published in 2011 that one of the ways for cancer to evolve is by evading the immune system. There is a old theory that was once rejected, but now it comes back, that there is what's called an immune surveillance. So the immune system does a surveillance of the body and can recognize the self and the non-self, and tumor cells that are recognized as non-self are being eliminated. And somehow we know that tumors can evade the immune system, and by doing that they escape the surveillance and they can grow and prosper. So basically, looking at the the entire immune system, we talk about two different parts that work interchangeably: the innate immunity and the adaptive immunity. The innate immunity is composed of the macrophages and the natural killer cells, and of course all the acute phase reactants and the and they complement a cascade. And basically this system activates immediately once there is a non or foreign body or a non-self, but the trigger to the immune system then later on initiate the adaptive immunity. The adaptive immunity is much more specific, although it takes time to initiate or to work. It is much more specific towards tumor cells, and we know that it is much more effective in killing tumor cells, so in recognizing the non-self and killing the tumor cells. However, we still, as I just mentioned, the tumors have the way to avoid or to somehow be undetected by the adaptive immunity. And I will try to explain in a few slides ahead why this happens. So when we look at this cancer immunity cycle, and I will start here at the phase 1, we know that tumors, once they grow, naturally cells die because of necrosis, apoptosis, whatever, and this causes the release of antigens, epitopes, those red dots here that are being taken by the APC, the antigen-presenting cells. The APCs then travel to the lymph nodes, and once they reach the lymph node, they present the epitopes, these antigens, which are basically peptides, to T cells. Those T cells then try to, that are recognized, or they recognize the epitope, and those cells are then the T cells that then recognize this. They are activated and they replicate, and then they are activated against the specific peptide, which is again originating in the tumor. So then those T lymphocytes migrate through the blood vessels or whatever to the tumors. And once they reach the tumor here, you can see that here is where the interesting interaction between the T cell and the tumor happens. The first interesting interaction is here within the lymph node between the APC and the T cell, but the more interesting one happens here. Once the T cell reaches the tumor cell, they are doing a co-stimulatory effect between each other, and the hopeful or the target of this interaction between the T cells and the tumor cells, hopefully, is that the T cell will kill the tumor cell. But as we know, this does not happen for some reasons, and that I will try to explain now why. So the T cells can be activated and can be inhibited. We see here on the left-hand side the activating signals, all those receptors that once they are activated cause stimulatory effect on the T cells, which cause them to replicate and so on. And there are the inhibitory effects. So all those receptors, once they are inhibited, all those receptors, once they are stimulated, cause inhibitory effect. Of course, if we block them, and this is the target for the new drugs, those inhibitory signals, if we block the inhibitory signals, then we will also have T-cell stimulation. So here now we see the big, or the major key interface between the T cell and the tumor cells. So as I mentioned before, this peptide, which is presented by the tumor, you see here in red, is first recognized by the T cell. So this is a stimulatory effect. Once this happens, the T cell can then will then try to be active against the tumor cells. But we see here that what will happen is that one of the things that will help the tumor to evade the T cell or the immune system is the inhibitory effect. This PD-1 receptor, which is a negative inhibitor, which is an inhibitory signal to the T cell, is activated by the tumor. So what the tumor does basically is that it inhibits the T cells that recognize it. Once the T cell recognizes the tumor will then inhibit the T cell that will try to activate against it. So what we're trying to do is, by using the new drugs, the anti-PD-1 monoclonal antibodies, is basically inhibit this inhibitory effect. And if we see here an inhibitory effect and positive effect, if we eliminate this inhibitory effect, we'll have only the stimulatory effect. So basically we will allow the T cell to be completely active against the tumor. So, and from this, what I just mentioned, or what I just generally described, is what is called the checkpoint inhibitors. So, again, looking at the cycle, we have this tumor that secretes these antigens. These antigens are taken up by the dendritic cell, the APC, what I just mentioned. And the first effect happens here in the lymph node. The T cell and the APC try to stimulate each other. The APC stimulate T cells that match those specific antigens, or the T cells that can connect to those specific antigens. So first, if the one inhibitor or checkpoint inhibitor would be the CTLA-4. So cells that are T cells that are stimulated by the APC, if we inhibit the CTLA-4, we will have more stimulatory effect. So this is the first checkpoint that is being used in the clinics. There are others that are less known, by the LAG3 and the TIM3. And if we continue to look, the activated T cell will then travel into the tumor and will just do what I just mentioned, the interaction between the T cell and the tumor cell. Again, if we will inhibit the PD-1, the checkpoint inhibitor, if we will inhibit the PD-1, we will have an enhanced effect against the tumors. So this is the basic immunological effect, or basic immunological theory behind the current therapies. But why head and neck? So why do we think it will be effective in head and neck? The reason is the load of mutation. So we know that the higher the mutation load, the more chances are that there will be a specific antigen or specific epitope to activate the immune system. And we see, if we try to look at this publication from Nature showing different kind of tumors with different different mutation burden, we will see that in the right-hand side, melanoma and lung cancer, they have much higher mutation burden. And we know already from the clinics that immunotherapy is very active in those cancers. So higher mutation load will increase the immune response. On the other hand, we will see all the childhood tumors, carcinoid, all those tumors that have very low mutational load. So head and neck is somewhere in the right-hand spectrum. So this is the first reason to suspect why head and neck would be efficient when we talk about immunotherapy. But this is not the only reason. So I've quoted here several researchers that show that head and neck cancer is a very immuno-related disease, and patients, for several reasons. First of all, patients comparing with normal subjects will have lower absolute lymphocyte count. The patients with head and neck cancers will have impaired natural killer cell activity, with poor presenting antigen function, with impaired tumor-infiltrating T lymphocyte that is, again, impaired and not function correctly. This will also inhibit, like, all the steps of the cycle. There's a suppression of the regulatory T cells. So all these, let's say, factors will indicate that head and neck carcinomas are good targets for immunotherapy. And indeed, we see here, this is not so updated table showing the current studies being done in immunotherapy in head and neck. So on the upper side, you will see the studies being done or that are about to open regarding the local disease. But usually in oncology, most of the data, and this is where you will see here, comes from the recurrent or metastatic setting. So these studies are about to be open, have been opened, or have closed and published. I will not focus on all of them. I'll just show you a few details regarding those three studies, the Keynote, the Checkpoint, and also the Keynote 048. And just have a look at the number of patients. So you see, basically, if you add them all up, it will be in the hundreds. So I'm guessing in 3 to 5 years, we will have robust data showing us in much more detail about the nature or the value of immunotherapy. I'll just point out that if you look at the target, most of the targets in immunotherapy are the PD-1, so the anti-PD-1, the anti-PD-L1, although there are the Tlr receptors, which I will elaborate shortly about. Okay, so this is probably the pivotal or the phase 1 that maybe initiated everything, showing that this was presented in ASCO, the last ASCO, presenting the anti-PD-1 antibody, pembrolizumab, activity in head and neck, the recurrent or metastatic setting. So patients who were in good performance status, who had recurrent or metastatic head and neck cancer, were treated with pembrolizumab, again, an anti-PD-1 monoclonal antibody. And this was done in a fixed dose of 200 milligrams once every 3 weeks for 2 years. And they were followed up. So we see here the basic demographics, nothing very specific to tell about this, but we see here that patients were in a good performance status. And also, have a look at this. This is just to indicate how many prior lines of chemotherapy or treatment the patients had. So we see that there's about 60% of the patients were treated with at least 2 or 3 regimes prior to immunotherapy. And we know that in oncology, treating patient with 2 or 3 lines basically means, especially in head and neck, basically it means he has nothing to offer. We have nothing to offer for that patient, and if we do, it will have very little response, if any, but not in the case of immunotherapy. So once patients were treated with immunotherapy, the overall response rate was added to about a quarter of the patients. 25% of the patients had a response, although complete response is quite rare. Partial response is quite common. And if you add the disease control rate, so adding the stable disease to that, you'll get up to 50%. So 50% is quite a lot for patients. Again, most of them were treated with a lot of lines before. So this is the swimmer's plot indicating patients who responded. So here you see only patients who responded to treatment. And again, you can learn a lot from these plots. You can see that it takes time for patients to respond. Usually in chemotherapy, we're used to having clinical response very fast. But here you see that the median time to response was about 9 weeks. So if you know you're starting immunotherapy to patients, you'll have to be patient about it. It will take time for them to respond, and if you need a faster response, I'm not sure immunotherapy is the way to go. But this we know from other studies, and this is the big, I would say, the big news about the immunotherapy. Patients that do respond have a long response. So we see all those black lines, and 86% of patients who responded are still responding for a long, long time, much more than usually for 20 or 30 weeks. Also, you can see that there are 2 patients here who had a response quite late. So after 20 weeks, after 2 years, they had partial response. So the immunotherapy probably takes time to affect the patient. But once they do, they have a durable response. So that's one thing to deduct from this swimmer plot. Side effects, this was a phase 1, so of course safety is the issue. Fatigue, hypothyroidism, we won't go into much of the details. Pneumonitis, all the itis, all the inflammatory response that we are very concerned about when we talk about immunotherapy. You encourage the immune response, so you're afraid that you'll get an immune response or over-immune activation. So there were basically no grade 4, no grade 5, and just a few grade 3, so not very toxic treatment. Another study that's did a lot of noise over the media is the Checkmate 141, which is basically a phase 3 study. And this phase 3 study, again, in the same setting, the metastatic head and neck patients, they were treated with either nivolumab, which is an anti-PD-1, or a second-line treatment. This was a patient for patients who failed the first line. What happened with this study is that although it was supposed to finish a cure estimately in September 2017, according to the clinicaltrial.gov, supposed to finish accrual in October 2016, but there's been a press release from MSD showing that the Opdivo trial was stopped due to early meeting the endpoint earlier than expected. I can't read from the computer, but it says here... לא רואים את החץ שלי? החץ שלי לא רואים? סתם שיחקתי בחץ? יש לך זה? יש לך שם, אצלי? מה יש אצלי פה? טוב, פוינטר, טוב. Anyway, it says here in the somewhere along the text that the endpoint was met earlier with a huge success. So this will be presented here just now in the AACR. So it was mentioned here that they stopped early because of an assessment from the DMC, concluded the study met its primary endpoint with superior overall survival in patients receiving Opdivo. This is the PD-1 inhibitor. Okay, so let's not forget that head and neck cancers also include the nasopharynx. There was a study that included patients with the advanced, basically most of them were metastatic nasopharyngeal carcinoma. And this study, again, gave pembrolizumab. This was a multi-cohort study, so different tumors were studied, not only nasopharyngeal carcinoma. And the dosage here was 10 milligram per ml. And patients were either responsive, and then they continued treatment for 2 years, or they progressed. I won't show you all the details, just this progression-free survival curve, and the data here showing that, again, overall response rate maybe a little bit lower, somewhat lower than the rest of the sites of the head and neck, and the duration of the response was 10 months. So, and it's what was quite safe to use. One more molecule we should be introduced is the Tlr Receptor Agonist. This is the motolinumab, the VTX2337. Basically, this agonist activates both types of immune systems, the innate and adaptive. And this is a poster presented at the Multidisciplinary Head and Neck Symposium of last year, 2 years ago, that shows the preclinical data that adding to cetuximab, this small molecule toll-like receptor agonist, TLR8, showed in the preclinical data higher response and higher lysis of cell, and also in patients, this is again phase 1 study, but showed overall response rate, again, disease control rate of 50%. So quite nice results. And if you look over the literature, there is a robust information. There's basically a lot of publications going on right now. I will urge you to read our friend and colleague Ezra Cohen's review in the JCO about the treatment of head and neck cancers, specifically relating to immunotherapy as well. So regarding the studies that are now being done in Rambam, and all of those not in Rambam or not familiar with that, I urge you to understand that our center has many options for metastatic patients, for recurring patients. So please consider referring them to us in case you feel it's necessary. So we have the Keynote 048, which is a phase 3 randomized control study. I'm sorry, I couldn't get the study design slide, but basically this has three arms: chemotherapy, standard of care, chemotherapy and cetuximab versus pembrolizumab versus pembrolizumab and chemotherapy. So 3-arm study that is supposed to accrue about 760 patients with primary endpoint of progression-free survival. Also, studies we have for second line. Just one note, we already enrolled 4 patients to this study. So regarding different studies that we also have for second line. So we have here two studies that are checking, again, PD-1 and PD-1 plus an anti-CTLA-4 antagonist, either by monotherapy or by combination, or comparing both, the combination to the single-arm monotherapies. And the patient will be stratified according to their PD-L1 status, either negative or positive. And we also have recently opened the EAGLE study, which is a phase 3 study, which will open for all comers, first line and second line, that will again compare the standard of care, the chemotherapy. The standard of care nowadays is the extreme, I mean the cetuximab 5-FU cisplatin, comparing to the immunotherapy drugs. So just to conclude, what will be our future direction, or what will we look at when we talk about immunotherapy? Probably combinations. So one therapy will not be enough. We will use chemotherapy, radiotherapy to eliminate or to try to bring more and more epitopes and antigens from the tumors that we kill by those agents to the APCs. There are now phase 1 studies doing just the same with melanoma. And we have some studies also in Rambam, phase 1 studies checking how to stimulate the APCs to be activated and take up more antigens and to be more active when they do a co-stimulatory effect with the T regulatory cells. And of course, the anti-CTLA-4 here at the interaction between the APC and T cell. And of course, we're talking about the anti-PD-1, anti-PD-L1 agents that will be effective once we discuss the interaction between the tumor cells, and hopefully they will allow for more killing of the tumor cells by the T cells. So probably combination, where there's now already phase 3 studies in lung cancers and melanoma, and probably we will see more and more in head and neck. So I will just take this opportunity to wish everybody, you and your loved one, Chag Sameach, happy holidays, and thank you.